Before we get started today, unsure where to listen? The More You NoCo is now on most major apps, including Apple, Spotify, Google, Stitcher, and more. If we're not on your favorite app and you're having trouble finding us and accessing the show, hit us up at The More You NoCo on Instagram. Private message us and just let us know what app you're using, and we'll hop on that train. What is up? Welcome back, listeners, to another episode of The More You NoCo with your host, Ivan Wayne, talking with a new guest from Northern Colorado each episode. Do you know what public health is? Well, our guest today is Dr. Lorann Stallones. She is the director of the graduate program in public health at Colorado State University in Fort Collins, Colorado. She's also a professor in the psych department there at CSU. And, are you ready for this? She's the deputy director for the High Plains Intermountain Center for Agricultural Health and Safety. Woo! During this episode, I tried to keep up. I learned a lot. She taught me a lot about public health, and we walked through a lot of very fascinating research topics and issues. Are you excited for today's content as much as I am? What are we waiting for? Let's go. Here we are, once again, another episode. I sit live in front of Lorann Stallones, and we are in her office today at CSU. Thanks for joining us.
Thank you for having me.
So we're going to walk through a lot here. And first, I want to cover that you have your master's degree in public health, and you have a PhD in epidemiology, which you received from a school of public health.
Yes,
I got that correct.
Yes, you did.
Okay. Also, it says that you're a professor in the psych department.
I am.
And you are the deputy director for the High Plains Intermountain Center for Agricultural Health and Safety.
Yes.
Did we miss anything?
The director of the graduate degree program in public health at Colorado State University, which is part of the Colorado School of Public Health. Okay.
Which is funny that I missed that because that's literally the reason why I'm here. That's what brought me here, is that role, your directorship of the public health program here for grad students. So I want to start off. On your faculty page online, I noticed that you had 3 separate, very influential stories about how you got here. Do you care to share those with us?
Sure. I'll start with the earliest one. My father was a public health professional himself. He was an epidemiologist, and from the time I was in kindergarten, I had to learn to tell people what epidemiology was. So it's the study of patterns of diseases in human populations, but a lot of people think it's a dermatology role, so skin doctor. So I had to correct people all the time, and he taught me to do that from a very young age. So I knew about public health forever. I never thought that it was going to be something I would do because I didn't think of myself as a science kind of person. When I was an undergraduate, I was thinking about going to nursing school. And when one of my father's former students, then faculty member at the School of Public Health, heard about that, she started sending me books on medical sociology because she was a nurse by training and had found her way to epidemiology and thought it was more interesting than the direct patient care. So she didn't want somebody else to go into nursing and then have to step out and do something else. So she was very influential in my decision to go and get my master's degree in public health. And also during that time, I wrote a paper in an anthropology class where it was really looking at the definition of mental health, and it was the changes in definitions in mental health in African countries where psychiatrists were being trained in the British system, and they would go back to their home communities, and suddenly people would become diagnosed with a mental illness when previously it had been viewed as normal behavior or behavior that could be managed, but it wasn't considered a disease. So I got very interested in how a disease becomes a disease.
Okay. Wow. So separate roads brought you here.
Yes.
And for those people who might be confused here at the start, what is public health? How would you put that in layman's terms?
that's one of those questions that we pose to the students, get your elevator speech. And I have to confess, I don't have one. Public health is addressing issues that influence health at a population level. So it can be a wide range of things. It includes restaurant inspection. It includes water quality. It includes diseases in the population, outbreak investigations. My own research has been largely focused on injury prevention. So it can be anything that impacts populations at a broad level, and then trying to come up with primary prevention activities so that those things don't happen in the first place.
And so this influence from you all probably manifests in 20 different ways. I mean, you got journal publications that are circulating in the academic environment, but you also have to have medical professionals out there translating this to the public. And is there also training of doctors and medical staff that goes on too? I'm just thinking about all, if we're trying to influence at the population level, where do we even start?
Well, you start at all of those things. So physicians are trained in diagnosing and treating diseases, and also understanding the difference between preventing a disease as opposed to treating one and reducing the consequences of a disease when it does occur. So yes, physicians are involved, nurses are involved, pharmacists can be involved. When you talk about the opioid epidemic, you're going to have a whole wide range of people who have to change how they perceive diagnosing and prescribing patterns. So it can be any of those things, and then also communicating with the general population, because we can't get people to change their behavior just by telling them something is bad for them. We really have to dig in. So psychologists can be involved, sociologists, anthropologists. I mean, the culture of our behavior is as strong in choices that we make as anything else. So anyone could become a public health professional, or people might be doing public health and not think of it as public health. If you're really trying to improve health and well-being, that can be viewed as public health. And the more we work together, the better our programs are going to be, and the more successful we're going to be with those programs.
Right. It takes a village.
It does take a village.
And it makes me think, gosh, that has got to be such an ambiguous release, right? Because you put out a message. Let's say you have the answer that will raise the average level of public health in a whole population. Just like you said, educating people about it, that's just the first step. And then affecting behavior and influencing people enough to where they don't just know it, but they start living a certain way and they change their behaviors. Or medical professionals hear what public health individuals are saying and they turn around and use that in their own practice.
Absolutely. And we have some wonderful examples of change. The change in cigarette smoking patterns in this country over the past several decades. That's a huge success for public health. But then it's countered by the increase in e-cigarette use. So you can't stop. We're never really done. Use of seatbelts, use of car safety seats for children. Those are new things in the bigger picture that really were promoted through public health efforts and policy changes. We have to have politicians involved to make some of the changes. The reason we have clean drinking water, it wasn't a single event that caused us to think that was a really important issue. So we're never done with our work. There's always something new.
Yeah. Do you think that is technology? Do you think it's human behavior that will always have ways in which we could be healthier? A combination of 10 different things?
I think it's always the combination, and I think that's why the models that we use include all of the different levels. So you have the individual, you've got the individual within the family, you got the individual within their social network, you then have the organizations that the individual interacts with at any level, and then you have all of those other organizations that impact whether you have health care available, whether you have the services available in your community. That's another level. So, and then you've got the the policy and the will to make the changes in the global scale. So I think it's all those things.
Yeah. In your time working in public health, is there a certain example that comes to mind where you just really wish people internalized your message more, or there's a certain topic that, man, in 2018, it keeps me up at night?
Oh, that's really a good question. I guess the one example that comes to mind right now, because it's kind of fresh, is bicycle helmet use. So you walk around campus and you see people riding their bicycles all over campus without helmets. And I don't understand why it doesn't get through. You're spending a lot of money to go to school. You're educating yourself. And what will happen if you fall off your bicycle or if you hit something is a brain injury. And so it could have a profound effect on the rest of your life. And we did a study many years ago looking at bicycle helmet use among college-age students on this campus and reasons why they did or didn't wear the helmets and circumstances where they did or didn't wear the helmets. And they wore their helmets for when they were using their bicycle for recreational use, but not when they were using them for commuting. So why do you think the rocks are harder than the concrete, or the rocks are more dangerous than the cars? It's a very interesting kind of perception that people have.
That seems like the opposite direction that I would have expected.
I think we were surprised.
Yeah. And not to mention the amount of times I see people going down the highway 65 miles an hour on a motorcycle without a helmet.
Yes.
That is another level, I feel like. I definitely, when I got into cycling, I did not wear a helmet for a bit. And then there was a point where I was probably going 15, 20 miles an hour, and I thought, a stone the size of a $50 could put me on my face at any second. What am I doing? And I went and bought a helmet that day.
That's really good to hear. I wish more people would do it. And I'm particularly disappointed when I see the public health students riding their bicycles around campus without helmets, because I think they need to be the role models. And so, when I was doing injury prevention many years ago, we would go to conferences, and the people who were trying to promote injury prevention, behaviors that would reduce injuries, would jaywalk across 4 lanes of traffic instead of walking up to half a block to a stoplight. And and so those kinds of paradoxes are things that we all need to examine in ourselves. I think there's a lot of messaging about what is good for us and what's proper behavior. But what does it take for us to get ourselves motivated to make that extra half a block walk?
Yeah, what's going on here? What is your opinion on some of the factors that limits this? Because if the people saying the message are struggling walking the walk that they're promoting, imagine the audience.
Absolutely. But I think we have a ability to justify the choices that we make and think that someone else making that same choice is wrong. And I think that gets into the psychology of just how we make decisions in our own lives. And a friend of mine used to say, we make the decision that takes the least amount of energy.
Right.
And our habits are built in, and so the habit drives the choice because it's the least energy for us. And so getting people to change their habits is work. Yeah.
And it's work for the person telling other people to change their habits.
Yeah.
It really goes to show how deep or how tall of a wall this is for public health to get over so many issues, because there's resistance to, it's inconvenient. It's going to cost me a couple extra steps in order to implement this in my life. Or, well, I have this habitual routine and I don't feel like it yet. I'll get to that next week or next month. And, I mean...
So the philosophy in public health is to make the easiest choice the safest choice. So it's taking away that individual energy in as much as possible. So, they tried automatic seat belts in cars.
Oh,
so if you think they were very inconvenient, but if they had worked, people wouldn't have had to think about putting that belt on. And so it's engineering sometimes the safer way that doesn't make people have to do something. They may not even know that it's going on. And there are things like that all over the place. That really have been driven by public health professionals trying to move society to the safer choices.
So do you think the path of least resistance is us simply not even being aware that we're benefiting?
That would be the ideal, wouldn't it?
Yeah.
That you didn't even know. But then how do you justify the support, the funding that you need to actually implement those kinds of changes?
Yeah.
So it's always an interesting, complicated dynamic.
Right, because sometimes people might think, oh, I don't want that. I don't want to not be made aware of things that I'm being influenced to do in order to be healthy. I want to make that choice.
Right.
That's interesting.
We live in a culture where people want to know and they want to make individual choices and independent choices. And that's the example of the person riding the motorcycle down the highway. Colorado was one of the first states to pass a motorcycle helmet law. It was also the first state to rescind it, and they've never had one in place again. So there are dynamic tensions between that individual freedom and that doing things so that people benefit. Immunizations are like that. You know, people want the choice of whether to immunize their children or not. Mm-hmm. And their concern is of an event that may or may not happen, that's a fairly rare event, to have an adverse reaction to a vaccine. But the implication, if everyone says, no, I'm not going to immunize my children, is the potential for major outbreaks of diseases that we think of as controlled. So we live in a society where the diseases aren't present here, but they could be if we don't keep up those practices.
Mm. You mentioned at the beginning that one of your research topics, or something that you've involved yourself with before, is how and when and by what variables do we determine something as a disease? Is that a very gray line, or is it different countries examine that and have it listed differently, or what does that look like?
Well, the physical diseases, there's sort of a universal coding system for cardiovascular disease and cancer and those kinds of things. But when a new disease emerges, it takes a little bit longer to reach the level of understanding and concern and to be defined as a disease. AIDS is a great example of that. It wasn't considered a disease because what they were looking at were consequences of having the HIV virus. And so it was other diseases in people that they didn't think should be getting it, like Kaposi's sarcoma and pneumocystis carinii in young, previously healthy people, that led them to go looking for why that was happening. And that's how it became a disease, because they found what the triggers were for those other conditions that shouldn't have been happening. So that's an example where the disease didn't exist because we hadn't named it and defined it and had a way to look for it. And I think with mental disorders, we tend to look at them based on symptoms, but different mental diseases may have the same symptoms, the same behavioral patterns. And those are difficult to kind of categorize. If you don't have a test that you can do and say, this is what this is, it's more difficult.
Yeah, do you have an example off the cuff of something that maybe at one point got close to being defined as a disease but did not make it, or something that we think of as a sickness or an illness but is not necessarily a disease?
Oh, that's a really good question. I guess my examples are more on things that we came to accept as diseases.
More of a social construct?
Yeah, I mean, you know, if the physicians didn't think it was a disease, it's not going to be diagnosed as a disease and it won't be counted. But if enough people come to enough physicians with the same scenario, then they start looking at it and considering maybe this is something that needs to be looked at differently.
What about the flu? The flu's not a disease, right?
The flu is a disease.
It is?
Yes. Influenza is a disease.
Okay.
There are specific viruses that are involved with influenza. When they talk about the vaccines and they talk about influenza outbreaks, they're not talking about an upset stomach. It's a very, very much a specific disease.
Today I learned.
But when we talk about having the flu, we might not have the flu. We might have symptoms that are similar to flu-like symptoms, and we call it the flu.
It's this piece. I'm sitting here, thinking, what would I call or not call a disease? And it's very interesting. You mentioned it's almost like a matter of total affected or inertia or things. We see a pattern enough to where we say, okay, this is a common problem. And is part of that like a public health philosophy that we label things as diseases so that we can educate other people and we can start turning around the epidemic and making people aware?
I think the disease issue is basically a clinician-related issue, and public health will use those categorizations in order to derive prevention programs around that. But most public health professionals aren't in the business of trying to define a new disease.
Right.
We're trying to identify those diseases that are out there that we have tools to prevent.
I see. Okay. So more application, forward-thinking based, not reactionary necessarily.
Yeah.
I couldn't help but notice through previous research of yours that you looked at pesticides research. And I kind of wanted to walk through this because I feel like this is getting more and more topical in 2018 with Monsanto and a lot of pesticides being sprayed on our crops. I don't know how much time you spent in this research, but did you find anything that still follows you today or anything that
I'm
stuck
still
to your
doing?
brain? Or that you're still doing today? Yeah.
Absolutely. I actually started... it started with an injury study that I was doing in Kentucky, and we were looking at death certificates and to try to figure out what was killing farmers. And in that study, we found about a third of the deaths were suicide, and hadn't seen a whole lot of literature on farmer-related suicide. So my research assistant at the time started reading a whole bunch of articles and books, and it was probably around the same time that people had begun to think that chemicals could cross the blood-brain barrier and have an effect in the brain. And there was a book called Molecules of the Mind. And in that was a story of a pesticide applicator who had a psychotic break and killed the family where he was applying the pesticides. It was cockroaches or something like that. And then he recovered completely. And so it got us thinking that with all of the pesticides and chemicals that farmers are exposed to, maybe we needed to do a deeper dive and see what might be going on. And there were, sure enough, going all the way back to the 50s, there were studies that documented some of the neuropsychological, neurobehavioral problems that pesticides could cause. Some in laboratory experiments, some with animals. Some of the pesticides are used actually to treat some psychological disorders. So we thought, maybe this is something that we should look into more. So then we started trying to put together the pieces to see if depression if there were increased rates of depression related to pesticide poisonings and exposures, which might then explain why somebody who had a poisoning or had been exposed to pesticides might kill themselves. So we did this is years of work. I mean, I started doing this in the 1980s, and it's still not completely accepted that what we believe might be true is true. There are people who don't necessarily accept that the compounds can actually affect brains the way that we think they do. But then there's another group of people who really are quite convinced that some of the organophosphates can actually do this to people. And so you can have an acute poisoning years before it can affect your brain biochemistry in a permanent way. This is our theory. And then it increases the likelihood that you might be depressed. And if you're depressed, you might be more likely to attempt a suicide.
Where do we start? Wow. I guess first thought, are these blood-brain barrier and mood disorder effects, are you thinking that they're from people who are applying pesticides, are people who are ingesting crops who've been sprayed with pesticides?
Yeah, well, the ones that we have been most focused on are insecticides, and so they would be ones that they might be applying them in your home to control insects. They apply them on crops to control the pests. It could be a pesticide applicator, for example, the people who do the crop dusting or the workers on the ground if you don't leave the field. And for the most part, we've done a very good job in the United States of reducing those exposures to those active ingredients in those compounds. But we've moved those exposures overseas. And so they're being used in developing countries at higher rates with less control, with less of the technology where you actually separate the applicator from the active ingredient through the whole course of the application. So it's still a problem, but it's not as big a problem, the things that we've been interested in the U.S. as it is in other countries.
Mm. And do you think some of that was due to public health, rising safety standards? Was it a byproduct of awareness?
I think a lot of the environmental protection kinds of things that came into play, concerns about the acute toxicity of some of these compounds. There's a lot of work that's been done on some of the chronic, some of the long-term effects of some of the compounds. And so it's changed the practices. So it's always the research part of the public health enterprise. You mentioned Monsanto. Well, that's a cancer concern. So it's a long-term exposure to a particular compound that has created all of the ruckus over the glyphosate.
Glyphosate, right.
Yeah.
Not the only, but I heard a couple months ago, I was reading that one of the concerns about Monsanto and widespread pesticides and then us eating them on crops is it disrupts the gut biome. So correct me if I'm wrong, but my current understanding is it's very good at its job, that it kills bacteria. And one of the issues is when we eat it and it goes into our gut biome and our stomach, it wipes out the healthy bacteria in there, which then opens us to a host of other issues that can come in and attack us because our gut biome, which usually would regulate what we're ingesting and perceiving from the environment, is now compromised. But you had mentioned cancer, and that seems like that's a totally separate conversation.
Yeah, you've walked into an area that I'm not as familiar with. The microbiome is hotly understudied now, and people are really looking at it from a lot of different angles. It's just not my area, and I haven't really been concerned at that level. I think new knowledge takes us down paths that we never saw coming.
Right. Yeah, this is not a conversation I thought I would have had 6 months ago, right? Yeah. So crossing the blood-brain barrier, for people who are applying these pesticides in our homes to treat insects and rodents and stuff, is it like it's touching the skin and it gets into the bloodstream, and then we think that is having an effect on the brain eventually?
Yes, there are a couple of different pathways for exposure. One is dermal, as you said, on the skin. The other is inhalation, and then you can also ingest the compounds as well. So if it's on your food and you eat it, that's another pathway for exposure. But probably the most common of concern is the dermal pathway. If you don't wash your clothes, if you don't wash your skin after you've been exposed, it's why people are told when they're using some of these pesticides in their homes to wear rubber gloves. It's so you don't get exposed dermally. Long sleeves, long pants.
Right.
Reduce your exposure.
And here's the power of public health, because at first when we start talking about this area of your research, I was thinking, okay, I'm not a pesticide applicator, so it's not on me to worry about this. But then I realized we sell these products to millions of people, and they're using them recreationally in their homes instead of, calling out the Orchid Man or whatever. People have these products in their home.
Yes, they do.
And they may not be aware.
They probably don't read the 2 pica print that's on the warning labels. I think we don't think of these things as being hazardous to us. And it's possible that they wouldn't be a problem because you're not getting a big enough of a dose to make you sick. But it's also possible that your child might get a big enough dose to get sick. Right. So public health runs the whole gamut of, if you're going to have pesticides in your home, have them locked away so that, kids can't get to them.
Yeah. What about a small amount of exposure over a long period of time? Would that match one really strong exposure?
There are people who believe that the answer to that question is yes, and there are people who believe that you have to have a full-on poisoning to get the effect that we've been studying. And I don't know the answer to that.
Right. Still up in the air.
Up in the air.
More research needed.
More research needed.
Science on.
Yes.
Yeah. Before, you have also studied how marital status might have played a role in certain health risk factors.
Yes.
Do you mind jumping into that?
That was a long time ago. That was my dissertation. And I was what would now be called a social epidemiologist. It didn't have a name back then when I was doing it. And in all of the epidemiologic studies, we know that marital status is associated with higher mortality. Certain marital statuses are associated with higher mortality, and they're associated with higher mortality from specific causes. So I was looking at cardiovascular disease, and what I wanted to know is if marital status is associated with cardiovascular disease, is the effect operating through what we would call standard risk factors for cardiovascular disease: blood pressure, cholesterol, smoking. And then, if the answer is yes, were those differences apparent before the change in marital status, or did they occur after the change in marital status? So that was the question.
And what were the findings?
Well, in the work that I did, it looked as though the differences in risk existed before the change in marital status, that it wasn't the marital status itself that was predicting. It just happened to more smokers became divorced, more smokers became widowed than non-smokers. So it was there, but it was present in that population, but the marital status probably... Maybe the reason they ended up getting divorced was because they were smokers. That I didn't do that work, but it was present before the change in marital status. Okay,
so your study was looking at people who had been married and then had been divorced.
Well, it was everything. Okay. So there was a long-term trial that had taken place, and so there were 10,000 people in the trial, and multiple opportunities for marital status to change. So it can change in different directions, right? You're single, you can get married. You're married, you can get divorced. Mm-hmm. You're divorced, you can get married. So I had to look at all those combinations and permutations of change.
Oh, so it's just the fact that your marital status did change.
Well, I looked at the specific changes, because it's the divorced and separated that have the highest, and widowed who have the highest mortality rates from cardiovascular disease. So I really wanted to focus in on some specific ones, but it got complicated.
Yeah. I'm sitting here confused trying to keep up with notes.
I had a big, huge piece of paper, and back then we didn't have the computers to do all this stuff for you. You had to do it you had to do it by hand. And I had to figure out what were real changes that might happen, what were changes that were coding errors in the data, and what were changes that I really could look at over the period of time that the data had been collected.
Right. So the risky factors were already occurring, and then we started going into this complex web of, well, what marital changes did they go through?
Right.
That's so neat. Public health, learning more every day right here. So we haven't touched on, besides the very beginning, your journey to Colorado State.
Yes.
So are you from northern Colorado?
No, I grew up in California and Texas. And
interesting combination.
Well, my father was a public health person. He founded the School of Public Health at the University of Texas in Houston. Oh. So I was in high school when he was offered that job, and we moved to Texas from California.
How was making the big old Texas move from California?
It was a cross-cultural experience.
such an academic way to put it.
It was looking back at the time, it was horrible because I was 16 and I had lived in the same community all my life, and so I didn't want to move. But it set me free in a way that I could then move around other places. I think I would still be in the Bay Area if I had never left.
This is an interesting proposition because as soon as you said it, I think I agree with that sentiment, and I think it sticks for a lot of people. That people who grow up in the same place, it's scary to move away for the very first time because 95% of the people you've ever known live within the same 50-mile radius.
Yeah.
And so what happened after high school in Texas?
Well, long path. I went back to California to do my undergraduate work. I studied cultural anthropology. I told you about the person who was encouraging me to study public health. So I went to my dad's school. I got my master's degree at the University of Texas School of Public Health in international health. I thought I was going to be an international person. Joined the Peace Corps, spent 5 months out in Micronesia, and found I didn't really want to live overseas. So I came back and worked for a while, and then realized that I really did want to get my PhD. And I wanted it in epidemiology. So I went back to the University of Texas School of Public Health and got my PhD. That was the marital status stuff that we worked for, that we talked about. Then I spent a couple of years working as a postdoc fellow in an upstate teaching hospital because I thought it would be good to learn to work with physicians as an epidemiologist. Worked at NIH for a couple of years, and then went to the University of Kentucky as a professor. It was my first academic job, and then I did that work on the suicide among farmers in Kentucky, and we were looking for a place to move west. So we ended up looking around, and there some of the people who had done some of the early work on the pesticides and the neurobehavioral stuff were here at CSU. So they had a job opening. I interviewed. I got the job. I came here, and that's kind of how I ended up in Colorado.
Yeah.
Still here.
When was that?
It was the end of 1989 when I moved to Fort Collins.
1989.
Yeah.
And so these were people that you were working with on projects.
I didn't know them.
Yeah.
I wanted to work with them. So I came here so that I could work with the people who had done some of that initial early work on the topic.
Right.
Yeah.
So you got to meet and work with people who inspired you and helped you develop research.
Yes.
So you're living the dream.
Yes.
Yeah. You mentioned that you spent some time living overseas and decided that wasn't really for you. Was it because you were so far from everything that you knew and everybody you had met to that point, or what were some of the intricacies of coming back?
Well, I think that I think there were probably a number of things. One, at the time, Micronesia was a trust of the United States, and so there was a lot of U.S. culture. You didn't really get away from U.S. Postal Service, dollars, a lot of contractors who were from the U.S. doing various types of work. So you didn't feel like you were totally in another country, but you were. So it was a dissonance between, not ever really getting to the point where you were adapting to living in a totally different place, because you keep getting slapped with kind of U.S. culture. I think that was part of it. I also went in as a health planner, and I got off the airplane in Micronesia, and the hospital administrator I was supposed to be working with for 2 years took one look at me and said, "I thought all health planners were men." And in the 5 months that I was there, that's all he ever said to me. And our office, we were in the same office. And you can't do your work in that environment.
No.
So it just, and I decided, if someone was going to treat me like that, I might as well be getting a salary. Because Peace Corps, you don't get a salary.
Yeah, you don't get paid at all, right?
You get a stipend.
Right.
Yeah.
How could someone in public health and a person accepting people in the Peace Corps be so prejudiced against women and have such a sexist ideal?
He wasn't from the U.S. He was a Micronesian, and it's cultural.
But that's a cultural piece that's hard for you to exist in.
Well, I think it's a misstep for the Peace Corps to place someone in a position like that. You know, if you think about the U.S. in the 1950s, it was okay for a woman to be a teacher or a nurse. That was similarly true at that point in time in Micronesia. So if I'd gone in as a nurse or a teacher, I wouldn't have received that kind of a reaction from the people I would be working with.
Yeah. Do you know if it's still the same in Micronesia?
I have no idea.
Right. That's hard because you understand it's located to a region and it's this cultural inertia, but at the same time you imagine and you see what it could be like.
I wouldn't use the word inertia. It's cultural values. It's just where they are.
Right.
And so you can meet people where they are to some extent. But if you can't do your work, then and you're there as a volunteer, there's less reason to stay.
Right.
Although I've got to say I do encourage people to do Peace Corps work if they have any interest, because you do get total immersion in a culture.
So being here in Fort Collins, well, first, let's not skip over Kentucky.
Okay.
What was your experience there? Did you enjoy it?
I did. It's a land grant institution, just like CSU, so it felt at home. I had been working with farmers in upstate New York. I'd been doing a lot of work with farmers, so I was looking for a place where I could continue to work with people who were in agriculture. It was very nice from that perspective. But I don't like the weather. You know,
how so?
There's not enough sun.
Oh, cloudy.
It's cloudy, and it's icy in the winter. It doesn't have snow, and it was just it just wasn't a great fit for the kind of lifestyle I wanted.
Yeah, you want to be outdoors and experience the sunshine and go hiking on something taller than the Appalachians.
Yes, all of that.
If I were to ask you, do you identify as a Texan, a Californian, a mix of both? They both play a strong role in your upbringing. What'd you say?
I'd have to say, it's yes. I probably they both played a significant role in my upbringing, and my family roots are in Texas. So my father's family, there were a lot of Stallones in the Houston area, and I had never in my life lived around anybody with the same last name. So that kind of rootedness was probably in the DNA somehow or other. But I think of myself as a Coloradan. You know, I'm here.
And it's not last year. You know, you've been here since 1989.
Yeah.
I also say that I've only been here a little over 4 years, but this is my favorite place that I've lived, and I really enjoy it. And I have tried in a short amount of time to invest and spread myself in the community. I've been a teacher in the community and I've served in several different ways, and just, I call it home now. The story how I got here is kind of random, but I also claim Coloradan, and I lived in Dallas, Texas right beforehand. So I tend to not say I'm not a Texan, from Oklahoma. So I agree with you. What's one thing you've enjoyed being up here in Fort Collins and this region of the country?
I think it's an amazing community. There's such a diversity of things that you can get involved with and engaged with. You know, whatever your interests are, somebody is doing it here. It was a wonderful place to raise children. You know, the schools are good. The support in the community is wonderful. I like having the university here. We bring in amazing speakers on this campus. I think it's a gem of a place to just explore things. You know, you might not remember this, but Obama came here twice.
Really?
To Fort Collins,
oh, wow.
to this campus.
Yeah.
And Michelle came once. It's a surprising place.
I wanted to get into what it's like for you on a daily basis as the director of the graduate degree program here for public health.
Yeah, it's a lot of meetings. You know, I still have a full teaching load. I still advise students, but there are a lot of details that have to be taken care of. There's a lot of emails that have to be answered. It's an administrative job.
Right. But you get to work with graduate students on an individual level.
Yes.
Enjoy that.
Yes.
Hear about their research.
Yeah.
And do you do any mentorship along those lines?
Yeah, the public health program requires a capstone project, and I advise about half of the public health students on their capstone work. So it's constant hands-on with, and we do that every single semester. So students are doing such interesting things. It keeps me informed about what's going on in the world and the community and different interests and stuff. So yeah, I work with students in that capacity.
What are a couple of neat things that just pop off the top of your head that graduate students in the program are working on?
One of the programs that we used to have was a Peace Corps Masters International program. So students could start their MPH, then go do their Peace Corps service, and then come back and finish their MPH degree. And we had one student who just completed her work, and she was in Guyana. And she did a study looking at the health information system in Guyana and what needed to happen in order to improve the data, the health data that would be available in the country. That was a wonderful project.
Yeah. It's got to be neat to watch other people's work blossom.
Yes.
Sometimes for the first time, as a graduate student.
Yeah, the capstone is a nice one because they don't think of it as their own project. And so watching them look around for something and giving them the guidance to choose something to take them to the next step in their professional career is always so interesting. We had a student who did a project looking at kind of sustainable rebuilding after a disaster. So after the earthquake in Nepal, because we have a tendency to ship in new building materials in countries where there's no waste management, which can create a huge public health problem. Having all of the waste there and the debris, and then bringing in new materials instead of trying to figure out what to do with the materials that are there. You kind of reduce the cost of rebuilding, but you also improve the quality of waste management by having less waste that you have to deal with.
Right.
So you never know what the students are going to come up with.
Mm. And I'm sure a lot of this comes from either passions that they've developed over time or critical issues they've found that maybe nobody else in the department has ever even considered.
Right. We had one student who did a project with the libraries, trying to figure out how to engage the libraries as a partner in sharing public health information. And I just thought that was amazing.
Yeah.
There's so many community resources that we tend to get, we kind of get in a silo and we think narrowly instead of broadly.
Mm. It's good to step out of that silo for a minute.
And the students make us do that.
Yeah, that's great. Being here 29 years, do you think that there are any Northern Colorado or Fort Collins specific public health issues? Either that were important when you got here and you've seen a great change in, or stuff that's still plaguing the area today, or that really needs to be addressed?
I think that one of the things we really need to address, and it's not just Fort Collins, is the lack of mental health care services available and safety nets for people. We have a high suicide rate. It's a problem, and we're lacking resources to help people. So I think raising awareness about suicide, raising awareness about the signs and symptoms, making sure there are more people in the community that are willing to engage in the difficult conversations with people who are struggling, and recognizing when people are struggling and just putting out your hand. I think we haven't done as much as we need to do in this community.
You think maybe there's a little bit too much of this personal responsibility emphasis on mental health? And instead we should be, I'd say, one step more than empathy, more than just empathizing with other people, but having systems in place so that when people have those awful times, those bad weeks, those bad months, there's something there, there's people there ready.
Yeah, I think that there's a tendency to shy away from the conversation about something as dramatic and traumatic as suicide. And there's a stigma with mental health that we still have. And there's also an attitude among some people that you can get better on your own. Just pull yourself out of whatever is going on.
Bootstraps.
It's pull yourself up by your bootstraps. Just get back, get out. What I do when I'm feeling blue, you should go out and try some things, and not really understanding how profoundly debilitating true depression can be. And I think that's education and awareness, and yes, making sure that you have the whole community, or at least a large enough percentage of the community, so no one feels so isolated.
Yeah, and just changing that awareness of, hey, the reason I think that X, Y, and Z will help your mood is I'm telling you that advice through a lens of my own brain and my own experiences. But we have to remember that we're sitting across the table from someone who has had zero of our exact same life experiences. So
that's a really good way to put it.
Advice can be good or it cannot be. And I think we can't be passerbys either. You're just walking by like, hey, I think you should do these 3 things. And then you keep walking.
Right.
And that can be hard on social networks if someone is struggling and having suicidal ideation. And so, not being in public health and not spending a lot of time studying this, I don't really have a good amount of opinion here, but I can see that it comes back to it takes a village.
Well, and anybody can go online and get QPR training, which is identifying signs and symptoms and learning about what you can do. And there's mental health first aid trainings that are going on in communities and stuff. And I think, the concept is if you get enough people who are trained in these ways and they are comfortable enough applying those tools, then it's like CPR for people who are in distress,
Yeah, can you talk a little bit more about this? I don't know that I've ever heard of this. Mental health CPR, essentially?
It's mental health first aid.
Mental health first aid, sorry.
But yeah, it's like it's creating a network of people who are trained in what to do, or and they role play, and you get comfortable in asking the questions and knowing enough about the resources in your community so that if you do have a conversation with someone that they need help, or you think that they might need some help, you know what to do instead of shying away, because we think of these as really deeply personal things that you might be exploring with someone. But so you have to be comfortable enough to ask questions. But you have to know what to do with the information that you get from a person. And so it's training to be able to do some of those things.
I have a hunch that several of our listeners might be interested in this. Can you kind of explain what is that QPR? Is that totally different? Or?
QPR is, you can actually do QPR training online. You just Google QPR and you can do it. And it's not very expensive. I think it's about $29. And you just do an online, it walks you through some of the signs and symptoms and what to do and what kind of resources that you would want to know about in your own community that you could put together. So that's a nice one that almost anybody can do if you have access to a computer.
Right.
The mental health first aid training is done around communities. I know that they periodically have them here in Fort Collins. It's a little bit, the training is a little bit more in depth, and it's a little bit more of a time commitment.
Right. Okay. Well, if any of our listeners are interested, please Google that. And just like CPR or first aid, you don't walk out of that class knowing you're going to use it. It's a maybe, and it's just that you're ready there and you can be there for someone if they need it.
Yeah.
I like it. I'm glad we got to plug that on this episode.
Me too.
Is there anything that is on your horizon in the near future for the Department of Public Health here at CSU?
We have just launched a certificate program. We're accepting applications for it right now. It's a certificate in public health science, and we would love anybody who would be interested in doing. It's a shorter version. It's not a full-on MPH, but if somebody decided that they wanted the MPH, all of the coursework would transfer directly into the master's degree program from the certificate program. So you can go online, Colorado SPH at CSU, find the link to apply. So that's one thing that's on the horizon.
Another outlet. And I want to ask you in connection with this, you all are promoting mindfulness with graduate students, and I think I read it correctly on the website that you're pairing with graduate students to promote mindfulness. Is this a piece of this mental health?
It's a piece of research that I started. A colleague of mine was doing mindfulness to see if it could be used as a suicide prevention program for adolescents on a reservation in Montana, and I got very interested in it as a tool, perhaps an additional tool for people. So we've done a few studies looking at training healthcare providers in mindfulness for themselves to reduce their stress. We've done some studies in businesses around Fort Collins area, Fort Collins Housing Authority, New Belgium, to see if it reduces stress and distress if you get trained in some mindfulness techniques. So that's kind of that work. I haven't done anything recently with that, but on the CSU campus there's a big push, and there are programs that are available for students to do a mindfulness-based stress reduction 4-week training. And it's done through the CSU Health Network. So there's lots of opportunities. And as I said, Fort Collins is an amazing community. We have Shambhala presence here. We have a lot of yoga opportunities for people. So and I think that for some people, these approaches can be very helpful in times of stress.
And for those who may not know, mindfulness is, to sum it up, bluntly, it's a form of meditation that is becoming aware of the thoughts that you have as you have them.
That's one piece of it. Yoga is also a mindfulness practice. So it's working with your breath. It's non-judgmental awareness of the moment, in the moment, and kind of feeling your emotions as you're having them, and recognizing them, acknowledging them, and recognizing that they will move on. But there are some very formal training practices that people do, and then there's some informal. So it could be meditation, it could be yoga, it could be something called body scans, and there are so many tools online for exploring different options. It can fit anybody's lifestyle if they are interested.
Very nice. And are you still researching these days?
I hope to be starting up some new research. One of the things that I want to be doing moving forward is looking at stress and stress reduction and suicide risk among farmers. We've got some projects under discussion where we want to get out and do some more work in that arena. Under
discussion. Very nice. As we wrap up here, if you had one thing you could leave people with out there who may have heard the term public health, but I would say many are not aware of the concept of public health and how we said it's kind of like secretly or it's subtly influencing everyone. For the general population listener, what do you have to leave them with as someone who has devoted her career in public health?
Oh man, that's a big ask. Again, the 30-second elevator speech. I think public health is everywhere. I think it's all around you. I think many of the things that you take for granted really are part of the public health system and network and have benefited people beyond their recognition. And I think that the tagline we should have is public health. Do we have a story to tell?
And that's a rhetorical question.
Yeah.
Okay. Because we do have a story to tell. Everybody does.
Yeah.
Yeah. Well, we'll close at that. Thank you, Lorann. Thank you for your time. And if anyone wants to reach out with you with email questions, would email be the best? Or,
absolutely.
And that's on your faculty bio page.
Yes.
Colorado State. And thank you for your time.
Sure. Thank you.
I want to say a special thank you to Russell Isaac Long, the man responsible for all the music used here at the NoCo. Are you looking for a little bit of bonus content in addition to the regular episodes on the show? Look for us out there on the interwebs on Facebook, Instagram, and Twitter, all at the NoCo. Until next time, peace!